Having discussed the acute leukemias, let us now move on to the chronic leukemias, which is going to include CLL as well as CML. So let's get going with the discussion of CLL, which is known as chronic lymphocytic leukemia, and I personally like to call this as the leukemia of exceptions because whatever we've read for the others is going to take a turn over here. This is the only leukemia which is not associated with radiation. So every leukemia, like say an AML, can occur following radiation exposure, but CLL would never occur. For every leukemia, I have told you that there is some translocation. Like just for an example, for ALL, I used to tell you translocations like 922, 1221. For AML, I used to tell you so many translocations about AML M2, M3, M4. But over here, CLL is not translocation, but deletion of chromosome 13q. Also, I've told you earlier that CLL is the one that is seen in elderly, usually above 70 years of age, and it is the most common leukemia that is seen in the Western population. So let's elaborate a little more on this. Like I said, that CLL occurs more commonly in elderly patient. You will have an elderly person coming to you with fatigue. Yes, fatigue is the earliest finding, and I can understand that some elderly 70-year-old man coming to you with tiredness. Blood cancer is not the first thing coming to your mind. But theoretically, yes, earliest finding is fatigue. After that, organ involvement can also occur, thereby resulting in enlargement of liver and spleen, that is hepatosplenomegaly, and enlargement of the lymph nodes. So how do you do the diagnosis? Let's assume if an elderly 70-year-old man comes to me with the tiredness and on palpation of the abdomen, I felt that maybe there is a mild hepatomegaly or maybe there is a lymph node in the cervical region. So the first thing I will do for anyone is going to be the blood test. So for the diagnosis of CLL, there is a 3-step criteria that has been put up. The first one says that do a blood test, and in that, because I say chronic lymphocytic leukemia, I am supposed to find the lymphocyte count should be more than 5,000. Absolute lymphocyte count more than 5,000. After that, the second criteria says, now I will not teach you the way it's written in the book. I will teach you the way you should be going ahead with the patient and how an MCQ would come. So the first thing is that you do a blood test and you found that the lymphocyte count is very, very high. Plus, he's an elderly person, 70, 72 years old. Now the bell rings and you're like, okay, maybe this is CLL. What should I do first? Let me find out what kind of lymphocytes are these. So the second thing that I go in for, because I've already got his blood sample, I'm not going to call the patient again and take another blood sample. No, I already had his blood sample. From that, I got to know lymphocyte count is more than 5,000. The same blood sample I will take and I will put it in the flow cytometry machine, which will tell me the status of the CD markers. If I get positivity of CD5, CD23 and CD200, means everything is positive. 5, 23, 200, when everything is positive, now I know I'm dealing with CLL. So now I'm going to call the patient and call him again the next day and go and plan his bone marrow, because in the bone marrow I will see that the lymphocyte count would be more than 30%. So in the textbooks it's written like this, but actually we take a blood sample. If we have lymphocyte more than 5,000, we go in for a flow cytometry. If all the markers are positive, 523, 200, then we go in for a bone marrow examination, and in that lymphocytes should be more than 30%. If all of three are fulfilled, it is a sure shot case of CLL. But obviously what is not in the criteria, but what I would do as a pathologist, if the lymphocytes are more than 5,000, I will have a look at it under the microscope. Obviously majority of the cells that I see over here are lymphocytes. So can I say it's like all the cells are wearing the same uniform? Similar to how one would dress up for a convent school, or similar to how one would dress up in a uniform for going to school, because all the cells look the same. They are all lymphocytes. This is why CLL is called as convent schoolgirl appearance. Apart from that, I can see some cells as if it looks that I took an ink dot and I smudged it. So that is what I call as the smudge cells. Now next is your imagination. You think this has been smudged like a parachute, you call it a parachute cell. You think it has been smudged like a basket, you call it a basket cell. The terminology is not important, the meaning is. Now many students believe that if smudge cells are seen, it is a sure shot case of CLL. No, this is a non-specific finding. It can be seen in infections like infectious mononucleosis, which is caused by Epstein-Barr virus. It can be seen in ALL also, it can be seen in CLL also. So this is non-specific. Now you would understand why the authors did not put smudge cell in this criteria. It's just an additional finding. But why does it occur? This is because the cells have lost a molecule called vimentin. Now, this theory that I'm going to explain over here is known as the cytoskeletal theory. This is the cytoskeletal theory which says that in these cells there is a loss of vimentin, which means first you should know what is vimentin. For every cell, like for a human body, a vertebrae, that's your backbone, right? For every cell, vimentin is the backbone. That is why every cell is standing erect and standing up strong. If the vimentin is lost, now the backbone is lost. Now the cells have become very, very weak. So just imagine, if you think these are the cells roaming inside a patient's body, no. Inside the patient's body, it is these cells, just similar to simple looking lymphocytes. When you take his blood sample and you put it on a slide, you put 1 drop of blood over here, and then we all know that we make a peripheral smear which is a tongue-shaped smear. So with another slide, when you put pressure, the cells were so weak that they broke. The cells are going to break on application of pressure during slide preparation. So can I say that these cells are not original cells? Smudge cells are basically artifacts, and who had prepared these artifacts? We have, because we apply pressure while preparing a slide and we end up breaking the cells. Reason for them being weak is because they don't have vimentin. Now finally, I would want to come down to, done with the criteria, let's understand the genetics better, because I told you it's a leukemia of exception. It doesn't show you translocations. It shows you deletion 13q. So for that, what I would do, I would draw a chromosome number 13 over here. This is the short arm 13p. This is the long arm 13q. And I'm saying 13q is deleted. To be very precise, inside 13q, there is an area, specific area that is deleted, and that is going to be microRNA 15 and 16. So when I say that 13q is getting deleted, it is actually microRNA 15 and 16 which is getting deleted, and that is why the patient lands up with CLL. Apart from that, deletion of 17p has also been noted. If you remember, 17p has the most famous p53. So yes, if you delete the policeman, anyone would have blood cancers. It can occur because of trisomy 12 as well, and it can occur because of BTK gene mutation. Hang on, I've read BTK gene mutation earlier. BTK was also mutated in Bruton's hypogammaglobulinemia. So B for Bruton, B for hypogammaglobulinemia, and it is also mutated in CLL. Now let me go forward that, okay, I've done the full criteria and the diagnosis of CLL in this elderly man, but now what else can happen in him? What are the transformations? I have a man who has CLL. Along with that, when I saw his, so CLL is a problem in white blood cells. When I saw his red blood cells had warm autoimmune hemolytic anemia. When I saw his platelets, he also has ITP. So when three things occur together, that is known as Evans syndrome. For those who have not read the platelet chapter, ITP is idiopathic thrombocytopenic purpura. Platelet count goes down basically. So how have I learned Evans? Evan is everyone, sounds like everyone, which basically means that RBC, WBC and platelet, everyone has gone for a toss. In the WBC there is CLL, in RBC there is autoimmune hemolytic anemia, and platelet there is ITP. So first transformation that I see is going to be Evans syndrome. The second one is going to be Richter's syndrome. Listen to this carefully. I am talking about a case of CLL, chronic lymphocytic leukemia. Leukemia means blood cancer. If this blood cancer happens to go into the lymph node, now it will be known as SLL. The full form of SLL is going to be small lymphocytic. In a lymph node, I will call it what? I will call it a lymphoma, small lymphocytic lymphoma. And at any point of time, if this small lymphocytic lymphoma converts into a DLBCL, what would that be? It's a diffuse large B cell lymphoma. So now I want you to see over here how small lymphoma has changed into big lymphoma. Repeat again, how a small lymphoma has changed into a large lymphoma. This is known as Richter's syndrome. It's like becoming rich. A small person has become a big person. He has become rich. So when I say that a CLL, SLL has changed into DLBCL, that is Richter's syndrome. The third transformation is going to be PLL. So what is CLL? You already know, chronic lymphocytic leukemia. If the cells become bigger and they become pro-lymphocytes, that is known as pro-lymphocytic leukemia. It's a more deadly leukemia in that case. Pro-lymphocytic leukemia is a diagnosis which is made when the pro-lymphocyte count, they are bigger than lymphocytes. When the pro-lymphocyte count crosses a 55%, that is when I say it is a PLL. So three transformation. Evans is everyone, Richter's is SLL becoming DLBCL, and PLL is when pro-lymphocytes are going to be more than 55%. Finally, if I go go back to the clinical features, sometimes these patients can also have lymph node involvement. So if I do a lymph node biopsy, first this is how a normal lymph node looks like. If I look at a normal lymph node, I will see that the periphery is going to be darker. Those are the lymphoid cells, and the center is very light because what is formed in the center is going to be the germinal center. You can see that there is a germinal center. This is what a normal reactive lymph node shows you. So this is what you will say, ma'am, these are follicles. There are round follicles created, and in those follicles you can see that the center is looking very white. That is germinal center. Normal lymph node is supposed to look like that. If a cancer occurs, then this pattern should not be seen. Now the cancer will show you only and only cancer cells. But when I saw the lymph node in a case of CLL, I could see something very similar to a normal pattern. I could see that yes, the peripheries were becoming darker and the center, like a germinal center, was very light. Can I say that it is trying to look like the normal pattern in CLL? I can't call it normal, I can't call it follicular pattern, so I'm calling it a pseudo follicular pattern. And what is formed in the center, these are not germinal center, these are known as proliferation centers. A lot of cancer cells are basically growing over there, so they start looking like the normal follicular pattern, but that is not. Finally, coming on to the prognostic effects. So like I told you that CLL is what? It is going to be chronic lymphocytic leukemia. But now a question in the end, I will tell you what I should have told you in the beginning because it will make more sense over here. From which cell is this tumor arising? Ma'am, common sense, it is arising from the lymphocyte. Which lymphocyte? The lymphocyte that has never entered into the lymph node means the naive lymphocyte, or the lymphocyte which has entered into the lymph node and gone into the germinal center, that is post-germinal center lymph node. So both. Remember, CLL can arise from the baby lymphocyte also, which you are going to call as the naive lymphocyte, and CLL can arise from the lymphocyte that has been exposed to the germinal center as well. More commonly, it arises from the post-germinal center lymphocyte, and that is the one that is going to have a good prognosis. Plus, I told you deletion 13q, which was actually a deletion of microRNA 15 and 16, that is also good. So deletion is what you're reading is good, and post-germinal center, which is more common, is good. So the most common genetics is also good. The most common origin is also good. All the most commons are good. Everything else is bad. If it is arising from a naive, a baby lymphocyte, anything arising from babies is bad. So baby lymphocyte origin, naive, is bad. If it starts showing you CD30 positivity, Notch mutation, ZAP70 positivity, or beta-2 microglobulin elevation, anything else mentioned now comes under poor prognosis. In medicine, you will also be learning that in CLL, there are two stagings that are followed. One is the Binet staging and one is the Rye staging. You don't actually have to learn what is all of these. You have to learn the last stage. So in Binet, we follow stage A, B, C. I realized in stage A and B, okay, because lymph nodes have to be involved, they are. But in stage C, the disease got so severe that apart from CLL, the other lineages also started getting hampered. RBC production went down, patient had anemia. Platelet production went down, so patient had thrombocytopenia. Similarly, in Rye, we don't go ABC. In Rye, we go 0, 1, 2, 3, 4. So I realized that in the last stage, again, along with CLL, the RBC production goes down, the platelet production goes down. So just remember, Binet stage C shows me anemia, thrombocytopenia. Rye stage 3, 4 shows me anemia and thrombocytopenia. Those are the advanced stages. CLL for you is done, which we famously called as the convent school girl because all of them were lymphocytes. Now we move on to the other leukemia, that is CML, or chronic myeloid leukemia. We all know that this is showing the famous translocation 922, for which I would first want to describe. Let's talk about normal, forget translocation. You and I, we have chromosome 9, and on chromosome 9 we have the ABL gene. We also have chromosome 22 on which we have the BCR gene. That's normal things that we have. But if there is a translocation that occurs, now this ABL will move from here and will come over here and sit over here. So can I say that now what I have is translocation 922, that is BCR-ABL fusion. Please note this BCR-ABL fusion has happened on which chromosome? On chromosome 22. So most students in the books read 922 is Philadelphia chromosome and believe that both of these are Philadelphia chromosome. No, Philadelphia chromosome is just chromosome 22 because the final fusion that is occurring on chromosome number 22. So Philadelphia chromosome is chromosome 22. Now, whenever this fusion will occur, we know the enzyme activity that increases is going to be tyrosine kinase, and that will result in CML. And this tells me that if I have to treat this patient, I can't go back and change the translocation. That has happened for a lifetime, but I can definitely decrease the level of this enzyme. Tyrosine kinase inhibitor will be used, which is by the name of imatinib mesylate. To note that this is the second time in pathology and medicine that you're reading imatinib mesylate, because this imatinib or tyrosine kinase inhibitor was, other than CML, earlier used in GIST also. Gastrointestinal stromal tumor also had an increase in tyrosine kinase, and that is why there also you gave imatinib mesylate. Another thing that you studied is that this is not the only place or only leukemia where translocation 922 occurs. Whenever translocation occurs and BCR-ABL fusion occurs, you have to ask the examiner what is the weight, because we have always studied that on BCR-ABL fusion, the protein can have three weights: 190 kilodalton, 210 kilodalton, and 230 kilodalton, and the leukemias will be L, M, and N. L will be that 190 kilodalton causes ALL, M will be that 210 kilodalton causes CML, and N will be that 230 kilodalton causes CNL, that is chronic neutrophilic leukemia. Over here, since I'm talking of CML, it must have been the 210 kilodalton protein which resulted in this. Finally, moving forward, if everything is about this translocation, then the investigation of choice here has to be fish. You know, color coding will always be given by the examiner. You have read that with gene genetics. So the red color over here has been given to BCR and green color has been given to ABL. So if I look at any normal cell, you said the red color has been given to BCR. So this is BCR and this is BCR, and the green color has been given to ABL. So there are two ABLs, which is fine. Two BCRs and two ABLs is fine. But when I go to the other cells, I can see over here that the red color was given to BCR and the green color was given to ABL. I can see one of each. Where are the other two gone? The other two have gone and fused. Yes, and that is why when red and green will fuse, the color that I will get over here will of course be a yellow color, which I can visualize over here. So yes, I can see a BCR-ABL fusion in almost every cell. The yellow color is coming. Investigation of choice turns out to be fish. So till now, the investigation of choice stories that I have done, I can make a quick recall over here. For ALL, CD markers were needed, so flow cytometry. For AML, CD markers were needed, so flow cytometry. But for AML M3, translocation 15-17 was needed to be proven, so fish. For CLL, again CD markers CD5, 23 and 200 were needed, so that is going to be by flow cytometry. But for CML, translocation 922 is needed, and that is why the diagnosis of choice is going to be fish, and that becomes a full-fledged table which will help you solve so many questions in your Q bank. Now moving forward, coming to all the pathology done, clinical features. Whenever we have a patient of CML, he comes to you saying, "Doc, I'm having a dragging sensation in the abdomen." Dragging sensation means he'll say something is pulling my abdomen down. Reason being that these patients have massive splenomegaly, and because of that spleen, huge spleen, he feels something is pulling his abdomen down. So of course, whenever you get a massive spleen, in our country, there are two main things you think of. If it would have been a patient from Bihar, Jharkhand, the infection you would have thought of is Kala Azar. And in leukemias, you would think of what? CML. You will do a blood test. On doing a blood test, I saw that there is a shift to left and basophils. What does that mean? Before I show you the picture, do you remember this entire series that I have taught you earlier? A quick revision. First cell is myeloblast. Then the biggest pro-myelocyte is formed. Pro word is removed, so myelocyte. Meta word is added, so metamyelocyte. Then band form, then neutrophil. So if I take your blood sample as a normal person today, I will see only neutrophils. But if I say there is shift to left seen, which means all the cells which were on the left, the precursors have also started coming into the blood, and that is what you see in CML. Not only do you see neutrophils, you will also see band forms, metamyelocyte, myelocyte, promyelocyte, even blast can be seen. Can I say you're shifting to the left? And that is what is called as shift to left. So over here, just for your quick revision, the one with the lobes must be the neutrophil. This with the lobes also must be the neutrophils. Then apart from that, I have some big cells. These must be the promyelocyte. I have cells with D-shaped nucleus. This must be the myelocyte. I have cells which are showing indentation. That must be the metamyelocyte. So I have an entire party happening over here. There is an increase in the WBC count. Obviously, it's a cancer. But along with that, there is shift to left. I can see all the precursors. That is why I call it a college girl or garden party appearance. If you remember, CLL was referred to as convent school girl appearance, because in convent girl, everyone is wearing the same uniform. Everyone was lymphocytes. But in college girl, everyone is dressed in pretty dresses and clothes. Same way for a garden party. So many different cells are seen. So I call CML as the garden party appearance. Not just that, you see a lot of eosinophils and basophils also. The first thing I taught you in this chapter was that basophils are increased in CML, and here you have it. But that's again not it. You have phases of CML that are asked in the exam. CML happens in 3 phases. If you don't give treatment, it goes through 3 phases. The first one is chronic phase, the second is accelerated, and third is going to be blast crisis. So we are going to have the CAB phases which are important for CML. Let's start. Chronic phase, the first criteria for all 3 is look at the blast count. See, this is a chronic leukemia. Blast count has to be less than 20, right? In chronic phase, the blast count is very low, that is less than 10%. In accelerated, put a little bit of acceleration, the blast count will become more, that is 10 to 19%. And in blast crisis, it is crisis because now the blast count has crossed 20%. Ma'am, once the blast count crosses 20%, it would be illegal to call it a chronic leukemia. If you're saying blast count has crossed 20%, it's crisis. This means it's no longer a chronic leukemia. It has changed into acute leukemia. Maybe it has changed into AML more commonly, or it has changed into ALL, because crisis, the count has crossed 20%. Not just cancer, apart from bone marrow also, in organs and other places, there are blasts seen. In soft tissues, the blasts have gone. So extramedullary, outside the bone marrow also blasts are seen. Hence, I call it a crisis. So remember, in chronic phase, less than 10, accelerated, increase the speed 10 to 19%, and then more than 20% is blast crisis. After this, if you see, chronic phase done, less than 10% over, crisis more than 20% over. This accelerated phase has a couple of other criteria. Number one, the blast count is 10 to 19%. Over here, the basophil count is more than 20%. Now please note, in the exam you are so much in a hurry to read only 20%, you forget to read what 20%. If blast is more than 20%, it is blast crisis. If basophils are more than 20%, it is going to be the accelerated phase. And of course, by now you would know patient has CML, you will start giving therapy. Imatinib you will start giving, and you will expect that, okay, if I am giving therapy, the treatment should show, response should show. But if you saw that the spleen is increasing, despite giving therapy, the spleen, massive spleen is not coming down. The WBC count is going either very, very high or it is going very, very low. The platelet count is going very, very high or it is going very, very low. Means, ma'am, nothing is coming in the normal range. This patient is not responding to treatment. That is also an indication of accelerated phase. Then they did more studies that why is this happening? Because probably some more chromosomal problems have happened in this patient. BCR-ABL Philadelphia is there. But apart from that, maybe the patient has isochromosome 17q and there is trisomy 8. Because of these additional cytogenetics, this accelerated phase is ongoing. Now, the latest update that has been released in 2024-25 and is, it's only in the blueprint and is yet to get published in the textbook, is that out of the chronic phase and blast crisis and accelerated phase, now only 2 phases are considered. They are seeing accelerated phases creating way too much of confusion amongst the residents and the physicians. So now ideally we should have the chronic and the blast crisis only. But as I said, this is too early an update to be omitted. This will still be followed in the clinical practice and it will take many years and months for it to get implemented as well. So for all practical purposes, you have the CAB phases. Let's move forward. If I give a summary of CML, did I say that it shows you translocation 922, patient has massive splenomegaly, the WBC count will go high, the basophils will cross 20%? Yes, because you have to compare it with the differential diagnosis, that is leukemoid reaction. What is leukemoid? Leukemia means cancer, oid means like. This is a cancer-like situation. It is not a cancer, but what is it cancer-like? What happens? In these patients, the total leukocyte count becomes very high. If you remember, the normal count was 4,000 to 7,000. If a patient comes to you with 55,000, 60,000 count, you will say, oh, does he have cancer? Immediately you think of cancer. But then when you realize that, okay, his count was more, but then you saw other things. Did you see basophils? No. Did you see any spleen? No. Then this is not CML if you don't see spleen. Did you see BCR, ABL? Again, no. Then what is it due to? This is due to infections. Maybe the patient has had such severe infection or sepsis because of which he is having a very, very high count. So only his count will be very high. Other features will not come. So count is high. It looks like a cancer-like, but is not a cancer because no spleen, no Philadelphia, no basophil. So what do you think? If there is too much of infection and too much of bacterial infection, which is the primary cell that you will see in this patient's blood? That is going to be neutrophils. So the last thing you do to differentiate CML from leukemoid reaction is going to be a lab score, which you need to know. So what is lab score? Some people call it lab, some people call it NAP. The AP is common to both, which stands for an enzyme called alkaline phosphatase. So basically, when I want to do lab testing, I am trying to test for alkaline phosphatase. If I call it LAP, it is leukocyte alkaline phosphatase, and if I call it NAP, it is neutrophil alkaline phosphatase. It means the same. Neutrophil is nothing but a white blood cell only, right? So LAP and NAP mean the same, and the concept is that you are basically counting how much of alkaline phosphatase is there. The normal score happens to be between 40 to 100. Normal score you have to know because they will say when is it increased and when it is decreased. So a high lab score would mean what? More than 100. Normal is 40 to 100. High lab score is seen in all these conditions. Before you start mugging it up, please note, in NAP score you are trying to count alkaline phosphatase where? I'm trying to count the alkaline phosphatase in the neutrophil. So just imagine if the neutrophil number increases, automatically the enzyme will also increase. So like now I told you, in leukemoid reaction, because of so many infections and sepsis, the neutrophil count was increasing. So if neutrophil count increases, NAP score increases. Pregnancy also, physiologically neutrophils increase, hence NAP score increases. Oral contraceptive pills can also increase neutrophils. Neutrophilia is obviously increase in neutrophils. Downs babies can also have increase in neutrophils, and sepsis, which is nothing but leukemoid reaction, is also going to show increase in neutrophils. So an easier way to learn this over here is going to be lakes and ponds. That is how most students have learned. When is the lab score increased? Kindly repeat with me. Lakes for leukemoid reaction, ponds, pregnancy, oral contraceptive pills, neutrophilia, Down syndrome, and sepsis. Neutrophil goes up, NAP score goes up. But when the NAP score become low means less than 40, that is seen in case of CML. You will say, ma'am, in CML there was garden party. Everyone was there. Neutrophils were also there. Why are you saying the NAP score is low? Because those are not normal neutrophils. Those are the neutrophils under the impact of Philadelphia chromosome, genetic problem. Those are abnormal neutrophils. They will not show you NAP score. Similarly, there is a disease called paroxysmal nocturnal hemoglobinuria. In that also, there is a problem in the alkaline phosphatase enzyme, and hence the NAP score is decreased. So low NAP score questions, it is seen in CML as well as PNH, and high NAP score is going to be seen in lakes and ponds. The normal NAP score is going to be 40 to 100. Before I proceed and with MCQs, because this is the end, the only thing that did not teach you and is important for INI-CT exam is that in CML, I kept telling you there's a garden party appearance, you do a blood sample, your diagnosis will be made, then you see Philadelphia chromosome by FISH and you are settled. What is happening in the bone marrow? Ma'am, is CML only a problem in the white blood cells? No. In INI-CT, they will say when Philadelphia chromosome problem happens, it affects all the lineages. It can even affect the megakaryocyte. Megakaryocyte is the precursor of the platelet. The megakaryocytes suddenly start becoming very small. If you look at their nuclei, which you will see, usually a megakaryocyte has lots of nuclei. Suddenly, in a case of CML, the megakaryocyte is going to become small. That is dwarf megakaryocyte. Easier way to learn it is CML sounds like a small, so you can remember small megakaryocyte is seen in this. Finally done with CLL and CML, ready for some questions. Mark the following statements mentioned below regarding CML, which is in the accelerated phase and incorrect. So accelerated phase, does it show blast 10 to 19%? Yes. Chronic phase shows less than 10%, accelerated 10 to 19, and blast crisis equal to more than 20. Correct. Are basophils 10 to 19%? No, basophils are more than 20%. I found the answer over here. Does it show persistent splenomegaly not responding to therapy, persistent platelet increase is not responding to therapy, all of these are true. The basophils count has to be more than 20%. That's the answer. The next question is a 49-year-old male who comes with complaints of acute febrile illness. Peripheral smear shows hyperleukocytosis, so the WBC is increased, and there is a shift to left with basophils. We know shift to left and basophils, characteristic of chronic myeloid leukemia. The next one is a good question. A 72-year-old man, known case of CLL, has a new finding, means some transformation has occurred, in which a lymph node has come up, and on lymph node FNAC, there are large cells with nucleoli and mitosis. What do you think? When ma'am CLL goes into lymph node, first it makes a small lymphocytic lymphoma, but description over here is not of small cell. This means SLL has changed into diffuse large B cell lymphoma, and this small person becoming a large person is defined as Richter's syndrome. So this is the exact answer that you would mark here. Which of the following leukemia rarely develops after radiation? The leukemia of exception, that is going to be CLL. Which genetic effect is seen in CLL most commonly? Deletion 13q, which we had read with a diagram. That is option B over here that is mentioned. Don't mess up out here. Which of the following conditions shows a decreased lab score? Normal lab score was 40 to 100. Decreased lab score less than 40 seen in two conditions, CML as well as PNH. First you get your answer ready and then you see, okay, PNH was written over here, that is correct. Okay, coming to the last question, the loss of which of the following components results in the formation of smudge cells? Smudge cells were artifact because the backbone is missing. The cells become weak and the name of the backbone is vimentin. Vimentin loss makes the cells weak and hence they become smudge cells. With that, not only do you finish chronic leukemias, but you finish the entire leukemia chapter and you are ready to take on to the next one, and that happens to be the lymphomas. So we'll be proceeding with Hodgkin's and non-Hodgkin's lymphoma.